All right, everyone, welcome back to our next lecture on joints. So we haven't had a lecture in a while. This is because we aren't having a lecture over the skeleton. So we had the first lecture on bones over the anatomy of bones, like the general anatomy, and then we went over some of the physiology with bone repair and remodeling. Then chapter 7 is mostly just the skeleton, so just looking at different parts of the skeleton, but that's why we have the bone list. Okay, anyways, we're going to start with joints for this lecture. So, what is a joint? A joint is where two bones connect, and the scientific name for a joint is called an articulation. So, you will hear a lot of this word either in text or in lecture, in labs. So, we have an articulation lab coming up, and it's going to be all about joints. And joints, importantly, allow our skeleton to move, which will be a lot of what this lecture is about. So we can classify joints based on three types of classifications on what binds the joints together. So again, remember, a joint is just where two bones meet, and those two bones can meet with different things joining those two bones together. So the first kind is called a fibrous joint over here. These are connected by collagen fibers. These are largely immovable. Good example of this is like the sutures in the skull, right? The skull has a ton of bones in it, but they are sutured together in fibrous joints. And this is what makes it immovable. And this is good here because we wouldn't want our bones moving around in the skull, because then if the skull bones are moving, it could potentially damage the nearby neural tissue, right? Your brain. The next kind of joint we have is called cartilaginous. These are joints that are adjoining bones by cartilage. So a good example here is your intervertebral discs. So we know that those intervertebral discs are made out of largely fibrocartilage, which allows them to resist compression. These have a varying amount of movement, right? Your spine does have some movement in it, more movement than like the sutures in your skull, which is zero movement, but not a ton of movement like our third category called synovial. So synovial joints have this specific synovial cavity here, and we're going to look at all three of these joints in a little bit more detail. So we have like a whole slide coming up on the anatomy of a synovial joint. So 3 classifications based on what binds the joints together. There's another 3 classifications based on the kind of movement that we can have. These terms are synarthrosis, diarthrosis, and amphiarthrosis. So our 3 terms here are referring to the types of movements that are allowed here. So for synarthrosis, this would be no movement. For amphiarthrosis over here on the right, this is some movement. And then for diarthrosis, this is like highly mobile. Now, generally, the types of movement is allowed by the types of adjoining features. So the highly mobile diarthrotic or diarthrosis joints are going to typically be the synovial joints, right? Because those are the ones that allow us to move the most. Synarthrosis, on the other hand, typically going to be fibrous joints because those are adjoined by these collagen fibers, which are not very flexible. And they're joined so tightly that there's no room for movement. But again, like in each of these areas, we do have the type of joint that we like, quote unquote, would want in this area to allow the kinds of movement, right? We want high amount of movement in some areas, and we want little or no amount of movement in other areas. So we can classify joints based on the binding, the way that 2 bones are bound to each other, whether that's fibrous, cartilaginous, or synovial, and then also the kind of movement that is allowed at that joint, either no movement, some movement, or a lot of movement. Synarthrosis, amphiarthrosis, and diarthrosis. So when we think about joints, I think just like before you would even, be in anatomy and physiology, if someone were to ask you about a joint, I think these types of joints is what we are most commonly thinking of when we think of joints, right? You see something like the shoulder joint in the top left, the knee, you see joints in the elbow. So all of these types of joints are examples of synovial joints. We'll come back to these a little bit later, but I think it's just interesting to point out now, right? Like we are very familiar with our own joints because maybe you've had an injury in one of them, or maybe you know someone who's had an injury in one of them. The highly mobile joints is kind of typically what we think of when we think of a joint. So it's a little bit harder to imagine like these sutures in our skull are also considered a joint. But again, it just has to do with the different classifications, right? One is highly mobile, joined by the synovial cavity, and then another is immobile, joined by collagen fibers. So let's start with the first one, fibrous joints. So we have three types of fibrous joints. We have a suture, we have syndesmosis, and then we have gomphosis. So suture, we've already talked about. These are joints held together by interlocking fibers, and these are completely immovable. So these are completely immovable. Immovable. Okay, the syndesmosis ones are joints held together by a ligament. The actual ligament can vary in length. Generally, it is longer than sutures, so there is some movement here. There might be some very small movement. Small movement. For here, the gomphosis, there's actually only one example of a gomphosis fibrous joint. It looks like a kind of peg in a socket. It's actually our teeth. So we have a periodontal ligament that holds the tooth in the socket, and this is the only example in our body of a gomphosis joint. So suture, syndesmosis, and gomphosis. But again, these are all held together by ligaments, or in the case of the suture, very, very short connecting fibers. So ligaments can be long or short, which can vary the length of the connection point of the joint. They're extremely short in suture to where you almost don't even see them. Okay, second one is cartilaginous joints. We have two here. We have synchondroses over here, synchondroses, and then we have symphysis here, symphyses. So the synchondrosis over here on top, these are also completely immovable. So an example of this would be like a growth plate, the epiphyseal plate in a bone. Now, once we're adults, the epiphyseal plate goes away and it just becomes bone. So we have like a remnants of the growth plate. But as the growth plate is still there, it's a layer of cartilage that's producing new bone, right, to allow the bone to grow. So while the epiphyseal plate is still there, it is technically separating bone tissue by cartilage here. But we cannot move the growth plate, and so this is considered a joint where two bones are coming together with some cartilage in between, specifically hyaline cartilage here, and it makes it immovable. Similarly with our ribs and our sternum, so the joint between the first rib and sternum is immovable, and the sternum itself is immovable. So it's because of this hyaline cartilage connection here. Even though they have different varying lengths of cartilage connection, both of these are examples of immovable cartilaginous joints. Symphyses, down here on the bottom, joined by fibrocartilage, a little bit more flexible. These are slightly movable. Right, so this would be an example of like the amphiorthosis. The term a few slides ago, that means a little bit of movement. And an example of this would be your vertebra, so connected by the intervertebral disc, and then the pubic symphysis, the small piece of cartilage connecting our two pelvis bones. Okay, the third and last type of joint is called a synovial joint, and it has a lot of structure to it. So on the screen here is kind of the general setup of synovial joints. The reason why they're called synovial joints is because they have this joint cavity that's filled with synovial fluid. This is like a lubricant. It's a lubricant to reduce friction within the joint, and the two ends of the bone here are actually covered in something called articular cartilage, which is just hyaline cartilage. So we've looked at hyaline cartilage before in our connective tissue. So we have hyaline cartilage on the ends of the bones. That way, if they come in contact, the hyaline cartilage will reduce friction between the two bones. But then even in addition to that, there's a full fluid-filled cavity called the joint cavity or synovial cavity that's filled with this lubricant called synovial fluid. So we have kind of two different layers to a synovial joint. We have the synovial membrane. This is that inner layer that secretes the fluid into this open space here. So it secretes that lubricant. And then we have an outer fibrous layer here. The fibrous layer is just going to be made of like collagen fibers. And we see that we have a ligament around it as well. And we know ligaments, again, from our connective tissue is also just made from collagen fibers. Okay, so we have 6 types of synovial joints. We have a plane joint, a hinge joint, and a pivot joint. So I'm going to show you 3 on this slide and then 3 on the next slide. So for the plane joint, this is where we have flat articular surfaces, and this is where we have bones kind of sliding next to each other. And the motion it gives is gliding. So it kind of looks like 2 boxes kind of gliding past each other. But remember, this is still synovial joint, so we would still have the cartilage there to reduce friction, and we'd still have the small fluid-filled cavity, the synovial cavity there as well. We have a hinge joint. A really good example of this is like your elbow. And this allows for flexion and extension around the joint. I kind of imagine this is almost kind of looks like a lint roller, if you will. So it would be like analogous to the humerus here next to it. But this allows hinge, so like swinging around a hinge. The next one is a pivot. This allows for rotation. And a really good example of this is your radius in your lower arm, because your radius is part of a pivot joint, and this allows for rotation around your arm. So plane, hinge, and pivot. Our next 3 are called a condylar, a saddle, and a ball and socket joint. Okay, so for condylar joints, they also allow for flexion and extension. It's just a different setup, like anatomically, from the joint compared to a hinge joint that also allowed for flexion and extension. But the condylar joints also have this biaxial movement. So there's like front and back, and then there's also side to side. So the side to side is going to introduce the adduction and abduction movement as well. The next one is called a saddle joint, named after the way that the bones kind of look like a saddle on top of one another. So here again we have the biaxial movement again. So we have flexion and extension around this joint, so kind of back and forth, and then abduction and adduction. So it can go kind of left and right and back and forth. And we have some more pictures of these types of movements coming up. Last one is called a ball and socket joint. This is multi-axial movement. This is the most flexible of the synovial joints. There's a lot of different types of movement it can have here. Because of that really deep like fossa that the head of a bone typically fits in for these joints, this allows for a lot of rotational movement. So we see flexion, extension, abduction, adduction, and rotation for these. Okay, so the types of movement by synovial joints. We're going to go through each of these one by one, and we're going to start with gliding. So gliding typically occurs where we have a lot of these short bones, like the bones in the wrist, where all of these bones have this articular surface next to each other, and they are gliding back and forth across from each other. So it's weird to think of that general anatomy of a synovial joint being here in these really small bones, but because these are synovial joints, they do have that general anatomy, right? So they have the synovial fluid as well as the hyaline cartilage surrounding them to reduce friction on all sides. These next ones, these are allowed by a lot of different types of joints, right? Or different types of synovial joints, but this is the types of movements in general. So we have here flexion going, this would be like flexion of the shoulder, moving your shoulder up. And we see here flexion of your knee here that decreases the angle between 2 bones. That's a little bit harder to define with the shoulder, because when you're moving the shoulder up, you aren't changing the like angle of the humerus relative to another bone like you are with the tibia and fibula and the femur here in the leg, right? So you see that little like right angle here. Extension is going to increase the angle between 2 bones. So again, it's really easy to visualize on the lower limbs here, but with the shoulder, extension would be moving it back behind you. And then the further you go back behind you, eventually once your shoulder is fully behind you, that is called hyperextension. So flexion and extension are occurring in the sagittal plane, right? The sagittal plane that separates right from left. So you're moving like kind of front to back in flexion and extension. So it's like your right and left body parts are moving within that like front to back plane. Because the right, I know, can be a little bit confusing using the words like front to back here, but that sagittal plane that divides left side from right side is cutting the body down the middle to like in that front to back direction, which is shown here. Right, so any movement along that plane is considered movement within the sagittal plane. We have extension, flexion, and hyperextension up here for the neck as well as for the entire torso. Right, so flexion is bending forward, extension is actually just sitting straight up, and then hyperextension is moving back. So this is flexion, extension, and hyperextension around the neck or vertebral column. Okay, we have a few more types of movements from synovial joints. We have abduction and adduction, and then circumduction. All of these are occurring in the frontal plane. So moving, like keeping your shoulder in line with your body, but just moving it away from your body or towards your body. And then circumduction is the one that goes around. Abduction and adduction, these can be a little bit hard to remember because the term sounds so familiar. And the way people typically teach it is adduction is like adding it to your body. So it's moving towards your body. So adduction is away, abduction is out. And then here's a chart that just has all of the movements that we just looked at summarized. So this is just for your review. Okay, one more thing I wanted to point out with the anatomy around synovial joints, they do have some extra support. So they have that synovial cavity that we talked about earlier, nearby ligaments, and the synovial fluid, things like that. But synovial joints also have two extra structures in order to increase stability and reduce friction. These are called bursa and tendon sheaths. So bursa is just a fluid-filled sac that helps reduce friction between two areas. So we hear one is between like the head of the humerus and then this like ligament that's going over it here. So just helping reduce friction between two. And a tendon sheath is the exact same thing. It's just kind of a longer structure. So a tendon sheath wraps around a tendon, and similar to the bursa, it's just this fluid-filled sac to help reduce friction with things rubbing against each other. Okay, so some factors influencing joint stability. So, and for joint stability here, we're thinking about kind of all joints. And then this is going to lead us into how joints can be injured. But because some joints are highly movable and some are immovable, the ones you can imagine that are immovable are pretty highly stable, right? Because if they're not moving, you can bet that joint is pretty stable. The more mobility you add into a joint, the less stable it becomes, actually. So our most mobile joints, our synovial joints, are actually the least stable, which is why we have a ton of joint-related injuries of our synovial joints. So the things that contribute to an overall joint stability is the articular cartilage, right? So I have this picture here of our knee joint, and we would see articular cartilage here. So this would be cartilage. This is actually the meniscus, and it forms, there's also articular cartilage on the femur that you see in blue next to it. So the amount of articular cartilage, right, this helps support joints because it reduces friction. If bones were to come together in contact with each other, if it was just kind of bone on bone, they would not really slide past each other, and they would create a ton of friction, which could damage the tissue. So articular cartilage helps with joint stability here to add a cushion and to reduce friction. The second thing here is ligaments, ligament attachments. So we see like this ligament here from the patella to the tibia here. It's this cord, right? This cord of dense regular tissue that is across the knee joint, and it's helping add stability here, right? You see other ligaments here as well, connecting the femur to the fibula there. So the amount of ligaments around a joint does also aid in joint stability. The third one is going to be muscles, muscle tone. So by muscle tone, we mean how strong the muscles are. So there are lots of muscles around these joints, right, which are actually the things contracting and relaxing and causing the movement of the joint. But their tendons are attached to bones in areas of this joint. So of these three, interestingly, muscle tone is actually the biggest factor to joint stability. And it's interesting to think about because if we were to think about ligaments being the main factor that influences joint stability, it would kind of make sense because ligaments are made of dense regular tissue. And you might remember from our connective tissue lecture that dense regular tissue is a lot of collagen fibers, really good at resisting tensile stress. But the thing with ligaments is because they're made out of dense regular, they actually cannot stretch that much, right? One of the examples we used of ligaments / dense regular was they're kind of like a steel cable, where they're really good at resisting tensile stress, but they can't really stretch, right? So if they get pushed past a certain point, they can actually just tear. Now, tendons can too. Tendons are also made of dense regular tissue, but tendon isn't the only thing around the joint here, right? So a tendon is connecting a muscle to a bone, and it's really that muscle, the muscle that's able to pull on the tendon, that's going to introduce a lot of stability into these joints. So oftentimes injuries around a joint tend to come from like muscle instability or muscle weakness, to where the muscle can't contract, or muscles around a joint can't contract strong enough to really stabilize that joint. And if it's not as stable from muscle tone, then things can tend to move around and go out of place more frequently. Okay, so let's talk about some joint injuries. We just have 3 to highlight here. The first one is a tear of articular cartilage. Again, articular cartilage is just a fancy word for like cartilage, right? Cartilage of a joint. One of the most common injuries of a tear of articular cartilage is a tear of the meniscus. So this happens when there's pretty extreme force on the meniscus, where there's like compressive and tensile stress on the meniscus. So cartilage can't like bend in a lot of different ways. So if there's too much pressure on cartilage in a lot of different directions, it can get damaged. When that gets damaged, it compromises that cartilage barrier, right, between bones. And the damaged portion of cartilage can actually start to hit the other side of the joint, and it can cause damage to the other cartilage or the bone around it. So often the way a tear of cartilage is treated, like a torn meniscus, is to just remove the torn part. So if there's like a little rough torn part sticking up on the meniscus, surgeons will go in and just clip it away. And now the remaining is smooth and it won't damage the rest of the joint. And it feels really weird, right? That if articular cartilage is playing a role in joint stability, that it's okay if we just lose some. And actually it is. It is okay if we just lose some. Like, it is normal to just cut out part of the meniscus, and that joint actually returns to normal functioning and pain goes away pretty readily. And again, this kind of goes to articular cartilage is not the main thing that is really supporting joint stability, right? It's muscle tone. So it's okay if we lose some of this here. The next type of joint injury is called a sprain. This is when a ligament is pulled too much. So if a ligament is pulled too much, remember I said just a couple minutes ago that ligaments can't withstand a ton of tension, or a ton of stretching, I should say. They are good at resisting tension, but they can't be stretched too much. Actually, your textbook had a pretty interesting stat here that ligaments can only be stretched about 6% of their total length before they start to tear, which is really not that much, right? And this is why sprains tend to be pretty painful, because these ligaments can be stretched too much, and then the more they're stretched, the more that they could potentially tear. So this is just due to over movement, like excessive movement in a single direction, that can overstretch a ligament. Ligaments can heal on their own. They do heal slowly, so healing a sprain does take quite a bit of time. They heal slowly because they're pretty poorly vascularized. Like there's not a ton of blood supply to ligaments, so while they can heal, they heal pretty slowly. It also does depend on the severity of the sprain. If a sprain is really, really bad, it might need surgical intervention, depending on if there's a really bad tear. But it can be really hard to put together these ligaments, like put the ligaments back together because they're very fibrous and it's hard to like sew fibers back together. Typically, again, these will heal on their own. It just takes a while because of the low blood supply. And speaking of healing on their own, cartilage injuries will not heal on their own because cartilage is completely avascular. So that's why this needs to be removed so it doesn't continue to damage the area. Okay, last one is called a dislocation. This is when a joint is moved out of, or bones are moved out of their joints. So a really common one is the ball and socket dislocations, like your shoulder or your hip. Again, this kind of goes to the idea that the more mobile a joint is, the less stable it is, right? So while ball and socket joints are actually the most mobile of our synovial joints, they are also the least stable. So that ball can come out of the socket. When it does, it's called a dislocation. The scientific term for dislocation is called a luxation, and there's degrees to this. You could have a full dislocation, like is what you're seeing here on the slide, right, where the humerus completely comes out of the socket of the scapula. Or you could have a partial dislocation where it's only slightly out of the socket, and if so, that is called a subluxation, which is a term you may have heard of before. So this could be a full dislocation or a partial dislocation, known as a subluxation. In order to heal these, the bones have to be returned to their original position, which is pretty painful because these bones, when they come out, you can imagine they cause damage to the surrounding areas, right? So oftentimes dislocations are accompanied by sprains because it's pulling on ligaments nearby because this bone is moving in a way, being stretched in a way, the bone can't be stretched, right? But the joint is being stretched in a way that it typically isn't. So it's often accompanied by a lot of inflammation, sprains, right? Pulling of ligaments, which causes a lot of pain. But if you just reset the bones back to their original position, the injury will heal itself over time.